Thank you everyone for joining. We appreciate you joining today's CME course on evaluation of mold-related disorders in an occupational setting, hosted by Dr. Meyer from the Selikoff Centers. Let's go ahead and move to the next slide. So on this slide here is the accreditation and the disclosure of this course. Again, the name of this activity is the evaluation of mold-related disorders in an occupational setting. And this is in accordance with the accreditation requirements and policies of the Medical Society of the State of New York. And just as a disclosure statement, the planner and faculty participants and all who have control of this educational content do not have any financial relationships with any ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. And then on the right here is also the notice of privacy. If anyone has any questions about the accreditation or the disclosures, please go ahead and put that in the Q&A. This next slide here is just a general overview of the Selikoff Centers for Occupational Health. We are who's hosting this course today. And as a general overview, we have 4 different locations. We are in Manhattan, Staten Island, Yonkers, and Suffern. We focus on advancing worker health through prevention-focused, high-quality clinical care. We have a multidisciplinary team, and we have expertise in diagnosing and treating occupational diseases, proactively assess workplace conditions to identify and reduce risk, and strengthen workplace safety through hazard identification, education, and targeted interventions. If you have any questions about the Selikoff Centers, feel free to put that in the chat as well, or send me an email following the course. But with that, I will go ahead and pass it on over to Dr. Meyer to begin the course. Thanks so much.
Great, thank you. Let me just find the sharing. Here we go. Daniel, is that up on, let's see if we can find the slide share. Is that got the right slide showing?
No, that's showing your 2 again.
Ah, okay. Let's fix that again. Right. Stop that. Close. Let's screen share 2. There we go. How's that?
Great.
All right. So we've got a full slide there.
Yep.
Okay. Just hide the meeting controls there so I can see mine. So thank you, everyone, moving in here. And as I worked through this, there, I realized that this is probably the subject of several hours worth of courses. So I'm going to hit on the salient points and then leave people some materials to go to if they need things, or happy to answer questions at the end of this here. So let me start off with a case. So this is actually one from back in my days at Connecticut. And there's some salient points here as to the type of person who we're going to see in indoor cases, particularly around mold. And I'll give you some of the history and background once we go through the case. So this is a 5th grade teacher who has worked for the past 20 years in her elementary school, teaching the top grade. And about 2 to 3 years before we initially saw her, she had developed a cough, which was sort of slow and insidious on onset. And it was worse at school. And according to the good occupational history taking, it would clear up in the summers. She'd gone to see her primary somewhere into this there and had about a year and a half worth of treatment for asthma with combination inhalers, occasional albuterol, and at times, particularly in the winter, she developed a URI. She occasionally received prednisone for that. Her past medical history wasn't particularly remarkable. She had an unremarkable pneumonia about 30, 35 years prior. She had smoked for a short spell and quit 20 years previously. Jumping onto her environmental history, she had a home that was new and dry, had central heating, central air conditioning, no pets, no hobbies, no humidifier, no hot tub. But her main complaints were around the school, where she was also quite symptomatic. She noted that there were roof leaks at the school, evidence of water incursion on the ceilings, and what she described as a moldy smell within her room. At the time we saw her, physical examination was normal. She wasn't wheezing, no other abnormal breath sounds. Office spirometry, when we put her on it, was normal. And so, given the descriptions, we chose to do bracketed spirometry. And this was particularly interesting. She had about a 20% drop in her FEV1, but also her FVC went down across the work week. And so this was spirometry done on Monday morning before she went to work, and then on Friday afternoon across at the tail end of a work week. Because of this and because she was feeling progressively worse and continued with a cough, she was pulled from work in February. We'd seen her, I think, sometime around the Christmas break or before school started. By April, she was actually feeling pretty good. She was off all her meds. She still had a little bit of what she described as wheezing, dyspnea, and cough. And then, excuse me, she was out of work from February, but of course the school year ended in June, and by August her spirometry was back to normal. She wanted to continue working, so she was transferred to middle school where she was teaching sixth grade within that school. She returned to clinic in late September, having been there roughly a month or so, and noticed again a cough, raspy voice. She was feeling much worse, noticed metallic taste in her mouth, fatigue, skin rash. Also began to tell us she was mentally confused. Physical exam showed no wheezes, but she had bilateral crackles at the bases, and a chest x-ray showed a little bit of right middle lobe atelectasis without any evidence of an infiltrate or signs of pneumonia. Now, it turns out, we asked her to describe her classroom. This workplace was much worse than the previous one. She again noticed moldy smells in the classroom, water damage to ceiling tiles, the skylights were leaking in the hallway. There was no basement to this school, but there was a crawl space under classroom, which was sort of filled up with dirt and debris. And just to add insult to injury, if we look at exposures, there was a mulch pile full of mulching or composting leaves just outside her classroom window. So there was no wonder with that environmental history that she was feeling considerably worse. Her spirometry, when in late September, her FVC was down about 20% from the time we had seen her in August, pre-baseline. She continued to work, scheduled her for full spirometry, and by early November, she continued to have that reduction in enforced vital capacity. And in the full set of PFTs there, she had a diffusion capacity, which was a little bit better than half that predicted. So she was considerably worse, and what we had suggested some form of potentially restrictive lung disease. And in December, of course, we pulled her from work. So I'm going to leave that case there for your consideration. We'll get around to talking about what that represents and what the diagnostic information was going to tell us. So we'll kind of move on to general facts about building-related illness, and I think it helps to consider the history of buildings. There in the 40s and 50s, post-war era, you built big building booms, lots of flat roof buildings, lots of modernist buildings, lots of buildings as compared to buildings out of the early 20th century that where you couldn't open the window. And so by the 1970s and the energy crisis and the cost of heating buildings, particularly public buildings such as schools, they made the buildings tighter by either building windows that were sealed or sealing up the windows, recycling the air more because you had to either heat it or cool it depending on the season. and in generally poor outside air intake. So what you got was air that was recycled through the ventilation system. And in general terms, you were unable or less able to open a window as you were in earlier buildings from the 20th century. Then on top of that came the recessions, the dot-com bubble, the Great Recessions in the 2000s, and companies and municipalities began to defer maintenance. If there were water leaks, you sort of plugged them up as best you could or put a pail underneath it, didn't replace the ceiling tiles, etc. So all of these, remember the kind of came to the fore in the late 90s, 2000s, 2010s as the buildings of the 1950s and immediate post-war era and into the 1970s became sort of older and maintenance and repairs weren't happening. So many people, and you kind of get the span of building related illnesses, anything and everything respiratory, from a cough, feelings of dyspnea, headaches, nausea, skin rashes, etc. And in general terms, although we're not going to talk as much about some of the general aspects of building related illness, NIOSH has gone out and found, and they did a retrospective review of their health hazard evaluations that found that over half of indoor air problems were just plain due to poor ventilation, and a lot of that has to do with the ventilation systems that if you put a lot of oxygen breathers, carbon dioxide generators together in rooms and you don't ventilate it well, you recycle the air, you bring in outside air, carbon dioxide levels, which are going to be in the 400 to 500 range, are going to go on up to 700, 900, 1,000. And give everybody headaches, fatigue, and irritability. Humidity can be high or low, both of them deleterious. You want to have a kind of a sweet spot in around the 40% range. Oftentimes, you would kind of try to bake things out of a building and keep the humidity low. And of course, with limited maintenance, a lot of dust gets entrained in there. So just to kind of, and this is just a sort of a typical picture. This happens to be from my hometown of Syracuse. As a post-war school building there, and you kind of see the tight windows. And I'll sort of point out one other aspect, not unique to Syracuse, but greatly emphasizes. This is a flat roof building in a city that gets 100 or plus inches of snow a year. So that flat roof has to handle not only the weight of the snow, but the snow melt with either the heat or the spring rolling along there. And you can just kind of picture how that might contribute to leaky roofs, water incursion, if maintenance doesn't continue on there. And of course, then we have our own examples nearby from catastrophic events. This is just one picture of many from Superstorm Sandy in 2020. So, kind of moving on, pollutants within building related illness. I mentioned many of them there, and big raft of biological agents, combustion products. Environmental tobacco smoke has actually diminished as a cause of building related complaints because of laws that have reduced the extent to which people are legally able to smoke within the buildings. So moving on to the biologicals, which is what we're principally interested in here in this talk, is that it's mainly associated with damp or wet environments, and water incursion is any kind of biologicals, but particularly molds and fungi love that water incursion. It gives them a nice surface on which to grow, sprout, divide, etc. So mold spores pretty ubiquitous within the outdoor environment, and so fungi again, just to sort of remind you, the eukaryotic cells and represent a separate kingdom from plants and animals. Been estimated anywhere from 10. Some people will even give figures as high as 25% of terrestrial biomass throughout the earth is filamentous organisms belonging to the kingdom of fungi. A couple of other things to remember is that they tend to grow and spread as mycelia, the big group of filamentous elements there, extending hyphae out from the growing area. And then they form spores to reproduce. And so the objective of the spore forming fungi is to produce as many spores as possible to go and reseed and to move them out along air currents or within air so that they're picked up, born, and settle in places where they can naturally grow and divide. Reminder too that they're heterotrophic. They tend not to be parasitic organisms, but they tend to be saprophytic or semi-saprophytic, is that they like dead or dying or inert organic matter for nutrition. That includes paper, that includes wallboard, that includes anything that is fundamentally carbon based and can get wet and provide a good substrate for them to grow on and use as a nutrition source. Now, because I mentioned that they represent at least 10% of the Earth's biomass, is that they're just ubiquitous in the outdoor environment. So if I set up an air sampler or an air trap outside this building, I would be able to tell you what spores are coming in off organic material, the bedding that the trees are in there that's coming out of us from the breeze from Central Park, all over. And I'm going to be able to sort of trap mold spores there. And there's a normal interchange of those in outside and inside air, particularly if the ventilation is adequate or you can open a window. So what that means, and we'll look at keep this factoid in mind as we look on later about how to understand the extent to which spores are present within inside air, is that in the normal interchange, if I measured the air outside and if I measured them in my office, which seems to be free of water incursion or frank mold, I would probably get roughly the same types, genera, and species, and the same concentration of spores inside my office as I get outside on 102nd Street. So the differences in type or number, if you go and measure spores in particularly water damaged building or building in which there's noticeable mold or evidence of mold growth or mildew, if I start to see differences between the outdoor species and numbers and the indoor, it means that I probably have, to some extent, abnormal mold growth within my building or, excuse me, water damaged area. I'll just throw up some names. Most of these will be familiar to most people in the talk there, and these are oftentimes the ones that you see associated with dampness and overgrowth within buildings, particularly things cladosporium and penicillium, alternarian aspergillus being amongst the most common ones. Don't neglect the gram-negative bacteria as well, because the overgrowth of those or some of the atypical bacteria, such as actinomyces, can often occur as well. And along with allergies, those gram negatives are also potentially releasing endotoxin there. So I throw that in, although it's a subject of its own later on about, excuse me, microorganism overgrowth associated with buildings. A little bit of a return to first year medical school type mechanisms of allergic airway sensitization. Just a reminder that allergens, because they're roughly in the order of about 2 to 10 microns, spores or some of the macromolecules from the mycelium, which are smaller still, get inside the airways, cross the airway epithelium, or they interact with receptors in the epithelium. They're taken up by macrophages, which are these purple looking guys here, which absorb them, bring them to the lymph nodes, present, they become antigen presenting cells to T cells, B cells, stimulate type 1 allergic responses, the B cell mediated allergic responses, degranulation of mast cells, et cetera, eosinophils, and stimulating the Th2 cellular responses. And of course, all of this leads to allergic sensitization and clinical manifestations of asthma, airway narrowing, inflammation, airway remodeling, bronchospasm, and asthmatic sensitization onward. So, a quick tour through allergic sensitization. Now, I mentioned the morphology of fungi, and remember that there's sort of two separate parts. There's the mycelium, all those threads of the cells, which are the non-reproductive growing parts of fungi, and then sporulation. Airborne spores are generally, again, because their intent is to become airborne, they're from 2 to 10 microns, which means they can be inhalable and deposited anywhere from the nares into the nasopharynx, the trachobronchial tree, and down into the larger airways. And penicillium and aspergillus, we see this very frequently and very heavily, spore forming organisms. Additionally, if mold gets disrupted, is not only is it are the molds and fungi pumping out spores to the atmosphere, but if it gets disrupted, segments from the mycelium may also become airborne, and these may be much smaller. They can be much smaller than the spores, as these pieces or segments of the mycelium may be a micron or less, and then these can get down as respirable fractions into the terminal bronchioles and alveoli. And these are typically proteins or glycoproteins. They're, as I say, structural components of the cell or the cell wall, metabolic byproducts of it. This list is not intended for you to know or memorize them there, but the underlying point is that many of these, excuse me, fungal genera will put out antigens that turn into human allergens. Now, if that isn't complicated enough, you want to remember also that fungi are putting out volatile organic compounds. So just a huge raft of low molecular weight organic compounds, aldehydes, ketones, sulfurous compounds, which give them their particular smell, as well as some nitrogenous compounds. And because they're volatile and they're organic, that's what's giving you that odoriferousness, that musty smell that you can sense at very low concentrations, because many of them, again, organic compounds, particularly sulfur or nitrogenous compounds or terpenes, they're going to irritate the mucous membranes. You breathe them in through your nose and throat, and they're going to start to cause irritation. Persistent or higher concentrations of these materials do tend to give people headaches and fatigue at higher concentrations. There are also some non-volatile cellular constituents. These aren't related to what you saw in the previous slide, the proteins, but these are beta 1,3 glucans that also are released and become airborne, although they're less volatile than the VOCs, and become nose and throat irritants. And high levels in buildings of these are associated, meaning that they're a marker for people and they're associated with cough and itching. So, again, a marker of exposure within that. Now, just to kind of restate the obvious, there's considerable disagreement and a lot of lack of consensus on what constitutes mold or fungal related illness. And I want to focus really on the most salient aspect of diseases or disorders or conditions that are caused and have pretty well demonstrated causes of particularly pulmonary illness, and those are the allergic responses, and particularly asthma and hypersensitivity pneumonitis. And these have demonstrable associations temporally with the exposure and disease onset. You've got fairly nicely reproducible physiologic tests, laboratory testing that can be confirmatory, and treatment that entails elimination and remediation of the sources. Now, to say all of that there, although we're focusing on molds and fungi, is you don't want to slight the other exposures. And again, you always want to think about things like ventilation is you see water incursion, but are people also feeling badly, feeling sick, so to speak, with a combination of these, plus things like poor ventilation, bacterial contamination, pests such as cockroach allergens, dust in the ventilation system, all the things that I mentioned that contribute to building related illness earlier on. So I want to talk about uh, approaches to the patients who have health concerns over mold and their indoor environments, and that listing a couple of symptoms and syndromes and disorders that are strongly suggestive of mold or moisture problems in the absence of any other alternative explanation. And the main conditions of concern are people who develop new onset asthma within that is ascribable or certainly is symptomatically traceable to the workplace, people with already extant asthma, because there's going to be a number of those people who go into a workplace and their asthma is exacerbated or even aggravated by problems within the workplace. Hypersensitivity pneumonitis, and I'll mention the development of sarcoidosis. And again, because it's so sarcoidosis is not well described as to etiology, but there is evidence that wet buildings and mold incursion do contribute to that there. And then some precursor conditions of that. These are not sort of one-to-one directions, but if people within a building, particularly multiple people, are developing recurrent rhinitis or sinusitis, complain of hoarseness or mucosal irritation, in conjunction with evidence of mold exposure, water damage, that is likely a precursor condition and may be early symptomatology that may then result in more severe disorder on an immunologic basis. So, how do we go about looking at people who complain of these there? And this sounds really pathetically stupid for me to say it there, but it's sort of a good rule for occupational medicine in particular to remember is that you have to establish a diagnosis, and that diagnosis has to represent a specific disorder with describable history, physical examination, and testing there. So, as I say, and my underlying point is that you can't have occupational asthma unless you have asthma, right? So there's no occupational asthma if someone doesn't have the criteria or meet the criteria for asthma or for hypersensitivity pneumonitis or pretty much for any disorder that you can. But you'd be surprised at how many patients, we certainly see them there, who have come with a diagnosis of occupational asthma, and their problems are something else. It could be sinusitis, rhinitis, vocal cord dysfunction, who knows, and that oftentimes because it gets attributed because people feel ill and then come in and note that they're mold exposures, that the doctors and, and their subjects or patients may be twisting themselves in knots, trying to make a diagnosis that fits the exposure. So that's my long-winded way of saying that you need to confirm the diagnosis first and then think about the causes afterwards. So that includes the occupational history, relevant findings on a physical examination, and specific testing. So for asthma, you don't have asthma unless you have, can be demonstrated that you have reversible airways obstruction. And we'll talk about ways of demonstrating that. For something that's a little less common but more severe, hypersensitivity pneumonitis, or spirometry and radiographic findings consistent with that. So look for asthma first and then think about the causal factors that are leading to asthma, whether you attribute it to mold or fungi or water incursion, contamination within the workplace, or that it's something else causing it there. Just to briefly touch on the diagnostic tests for work-related asthma, I won't belabor these, but of course spirometry and a reduced FEV1 and sometimes a reduced cross-shift FEV1 is a good way of demonstrating its association with the workplace. So you can bring people in Monday morning after the weekend, put them on the spirometer, and then either test them depending on their availability or what you think about the exposure, test them again right out of work, or test them again. I'm sorry, there's a misprint in this slide. So it could be Monday morning and then Monday afternoon, or Monday morning and Friday afternoon, after they've gone a work week there. And in broad brush general terms, can vary, but if you see a drop from their unexposed Monday morning spirometry into their Monday afternoon or Friday afternoon exposure, is that you've oftentimes got a good criteria for an association with the workplace. Doesn't tell you what it is, but it tells you that there's a good chance it's associated with that workplace. Peak flow measurements, I'll show you that on the next slide. They're very useful in the workplace. There is that you'll start to see drops at work and improvements in nights and weekends. That's a good way of getting multiple data points across the course of a week, and put it together with cross-shift spirometry, you're on better standing. Allergy testing, if you can identify what particular allergens are, that goes for biologicals as well as many other materials, such as animal handlers and animal antigens or allergens. You can get specific, or latex allergen specific serum IgE or skin prick tests. Here's a nice example of a peak flow diary. People can bring in the numbers, but they oftentimes look better if you're graphed. And so this may be a little hard to see, but the open triangles represent work, and the solid circles represent this person's peak flow rates at home. And kind of a nice, this sort of looks like a weekend because they have almost 2 days at home, in which their peak flow is nicely up there in the 600, 700 range going to work, the open triangles, and it drops down by about 20, 30%. Go back home and it's back up to your baseline and dives down again on those working open triangles. So a nice way of being able to demonstrate occupational asthma in at least its association with some type of exposure at the workplace. I'm going to focus a little bit on hypersensitivity pneumonitis. We see this less, but I think one of the reasons we see this less is because you have to think of it to be able to make the diagnosis. And we've oftentimes seen patients in here who uh, have an attribution of asthma, and on a closer look, we'll show you some of the diagnostics. A closer look, they turned out to have HP. Brits call it extrinsic allergic alveolitis, which is a better description of the pathophysiology, what you see on the CT scan. And big list of candidate antigens. The thermophilic bacteria are often seen in farmer's lung, but it's not only related to fungi and mold, such as aspergillus, but the bacteria that are somewhere in that middle ground between the true bacteria and the true fungi, actinomyces and mycobacteria, along with animal protein. So pigeon fancier's lung has been long well known as that rather than fungi or bacteria, that antigens from birds can cause that. And in the workplace, sometimes chemical haptens like isocyanates also cause. So the excuse me, the clinical presentation is pretty variable, and that's what keeps us from finding as much of it or understanding it, or oftentimes seeing patients who come to us misdiagnosed several times. There is that the acute illness oftentimes looks like pneumonia. They complain they're fever, they're dyspneic, they've got myalgias, they're tachypneic. You might hear wheezing, you might hear some rales. And I'll show you on the next slide. Actually, I'll show you briefly now and come back to this slide. This is a case of farmer's lung, and you can sort of see this sort of somewhat widespread, fluffy, infiltrative looking findings down excuse me, over here in the right lower lobe area. And if you took that picture and it didn't give you any history from it there, you might actually believe that that's somebody with a community acquired pneumonia. And this is oftentimes what happens is people go to their primary or they go to the walk-in clinic, give them the history that you see above in this slide there, gets diagnosed as pneumonia, get an antibiotic, but what helps you recover from that is the fact that you're given time away from work. You're not going into work. And so that exposure is no longer evident and giving you the symptomatology right now. It's only when it comes into sort of later stages and you start to kind of work that up is that people complain of a chronic cough, exertional dyspnea, and you start to do more tests there. And as you saw in this next chest film will oftentimes show this infiltrate, which is from the alveolitis, but then with prolonged exposure, and as this becomes worse, it'll progress to that interstitial pattern with honeycombing. So here again, this is farmer's lung, and the infiltrate here is alveolitis. It's sort of patchy, widespread, and diffuse. But again, sort of your quick and dirty look might tell you, in the absence of a lot of occupational history, maybe that's community acquired pneumonia. Better for it still, if you're at all suspicious for it, is the high resolution CT, and these are the patchy infiltrates of alveolitis showing up as ground glass opacities pretty much throughout all the lung fields on this CT, and a fairly classic picture of it. Of a acute or acute to becoming chronic um, case of HP. Here I mentioned that later the interstitial fibrosis and honeycombing is evident there. And so this is somebody who was mold exposed in a long-term building. So just as, again, sort of a patient anecdote, we've had at least one, and I think probably a couple even here, who have come to us described as having been treated for either pneumonia or for asthma, and you have to sort of stop and take a moment and recheck everything here. And I'll remember one particular case that I saw with one of the residents. had been diagnosed as pneumonia, albuterol inhaler. Sorry, had been diagnosed as asthma, albuterol inhaler wasn't seeming to working, and don't remember if it was a pulmonary doctor or allergist had put her on a spirometer, and she had a FVC, so forced vital capacity, that was about 60 or 65% predicted, that was indicative not of asthma, but of course of restrictive lung disease. And remember that the PFTs are more likely or going to be more typical of of a restrictive disorder in HP. So if the numbers and you're reasonably assured that say it's a good spirometry and the like, if they don't add up, you want to rethink that diagnosis of asthma. And this turned out to be a case of HP related to a fairly extensive but not very long mold exposure at work. So again, the evaluation, the occupational history, the home, and in HP you can get IG, what are called precipitating antibodies, or precipitants, which are IgG to candidate antigens. There are not many of them there. The panel that you get via most of the commercial companies is about 6 to 8 candidate antigens, so it won't cover all the possible exposures there. And again, another anecdote: we had somebody who was living in an upper floor of a old and decaying brownstone building with a hole in the roof and a number of nesting. I forget whether there were sparrows or starlings within and under the roof. Um, and clear evidence, particularly from a restrictive PFTs and a high res CT, that she had an early case of HP. There are candidate antigens. You can get pigeon antigens there. We've looked all around and finally ended up writing to our friends at National Jewish in Denver to ask if they had any precipitating or IgG antibodies to any birds other than pigeons. Did you have them for starlings? And they said, no, sorry, but given your history and the like, it sounds like a reasonable attribution, even though we can't give you those to those particular birds. Um, all right, so you've worked on the diagnosis, linking the diagnosis with exposure, and the key is not to go run off and test for everything right at the first thing. In the words of Yogi Berra, you can observe a lot just by watching. And so what you want to do first is the walkthrough and just look at the place, look at what the possible sources are, look at what could be causing it, and do some judicious sampling. And not only for mold, go and sample the humidity, sample the dampness of materials. You can actually plug in and see whether or not the wallboard or the ceiling tiles have a higher water content than they should be, as well as the air around, the ambient air within the workplace or within the school. Measure carbon dioxide, particularly when there are people around, if it's a regular workday. These are some extreme cases of mold there, but it just kind of goes to just indicate that you can probably figure out what the sources are pretty easily just with a walk around and some simple exposure sampling. Um, and the things you'll see in the walkthrough is that most of these are not surprising. Most of these are not mysterious. You don't necessarily have to look behind walls to look for moisture and the like. You walk through and you look for signs of water damage. Are there stained ceiling tiles? Is there evidence of leaks? Is there condensation in the windows there? Is it humid inside or outside? And there's condensation on the windows, particularly if you get cold and humid environments, like my hometown of Syracuse, that lead to high humidity inside and a cold outside that's going to condense and drip down from the windows. standing water from the air conditioners and humidifiers, of course. Look for a lot of porous materials. There's around, particularly in uh, places like elementary school, you like to give the kids kind of a homey environment. You have stuffed furniture. You have, excuse me, you have carpets. You have lots of porous materials, and the kids are going to come in wet shoes, wet boots, lots of playing around, particularly some animals maybe, and those porous materials are going to first get wet, and then they're going to serve as a really nice breeding ground for that. Look for plants as well within that there. So lots of potential signs. Again, just a careful look around should be able to tell you things, and people will point things out to you as well. Things to look out for around the immediate environment. I mentioned the compost pile that was outside our teacher's classroom window, organic material, the bird droppings, bat droppings, plants, grading. So oftentimes schools and many buildings, even small office buildings, may be built with slab on grade and get floor condensation. So that may seep up. And even if the rugs over that slab, you may get condensation in and around, or water rising up onto those areas there. Crawl spaces are another bad actor as well if there's no evidence of a basement there. And the HVAC systems are really key. You want to just, many places aren't going to spend the money or the time or the effort on clearing out the HVAC system unless they have to, or they'll keep on deferring maintenance and the like. So look at the filters for microbial growth, and look at the heat exchangers, the ductwork, microbial growth, and the like. So, what do you do when you start seeing that? How do you then go about testing in the mold? And so, there's a variety of ways you can do this here, and the simplest is what I call the grandmother test, which is actually what's favored by oftentimes places that provide us with advice on assessment of water damaged buildings and mold overgrowth. So, the California DPH and their environmental health laboratory branch says that if you do, measure moisture, observe the dampness, observe whether mold, and those assessments have actually shown much stronger associations with health effects taken as a whole. So this is going to include things like rhinitis and sinusitis and upper airway disorders, as well as asthma. Uh, those have stronger effects than microbiologic measurements. Odds ratios from 14 down to about 3 for measurements. The State Department of Health says visual inspection, focus on locations where water and mold growth are, and speciating them, as they call it, generally irrelevant to your process. So the grandmother test, if your grandmother would look at it and point it out and say that's mold, then you're probably looking at mold. So this is oftentimes favored by the groups that are particularly mostly concerned with exposure to groups of people and remediation of those exposures. You can do bulk or source sampling there. The advantages of it are that it's going to give you the genera and species of the visible mold growth, and you also want to perhaps do swabs or tape lifts from other areas for comparison to show that you've got demonstrable mold growth on wet areas vis-a-vis that it's not in the dry areas. Some criticisms of that approach, as you can imagine, is that it may not represent the distribution of airborne species. So you may have spores from other species present that are not necessarily represented by what you took as a bulk, as a bulk or a source sampling there. And you don't get much information about how those compare or contrast with those on the outside of the building, because you're not going to be able to take similar bulk or source sampling from outside the building. But if you see visible mold growth and want to briefly or quickly speciate it, then that's a good way of moving. Air sampling tends to get the most attention for that there. Now, remember that these are picking up spores, and so there's good and bad and ugly as to air sampling testing is that you want to do it in areas where you both see mold growth or water incursion, and you want to do it where your workers are located. And again, that seems pathetically stupid, except that some samplers, depending upon what they're doing, are just going to sample from random rooms or areas within a building rather than the areas that may be of greatest need or where the workers are complaining of it there. With air sampling, you can do comparison. Remember, I talked about indoor and outdoor building locations there. And what you want to get when you sample is to see a difference in genera and or species and concentrations that differ from indoors from outdoors to indicate that there may be mold overgrowth or species that are more likely to be, if you will, pathogenic, causing asthmagenic or immunogenic species. But remember, some of the caveats is that sporulation may not happen at all times of the year, and that may not reflect worker exposures. And then there are molds or fungi that are non-sporulating, and Stachybotrys is amongst the most common or well-known mold that doesn't necessarily sporulate. So you may get Stachybotrys on bulk sampling, but you may not get it on excuse me, air sampling if it doesn't form spores. Now, here's sort of just briefly a typical spore collection, and this is useful because what they did was to sample the outdoor air and the roof, and then what's marked upper level is within one of the rooms here. And without going in great detail through it, I'll just sort of point out the relevant factor here is that you have let's over here on the left side on the roof here, you've got a number of very common outdoor fungal species, ascospores and basidiospores, making up the bulk of it there. Many fewer within that room, but some of them will have come in from indoor air. Where the money is over here are looking at ones that are more common in damp or wet areas, penicillium and aspergillus, 9% up on the roof, but representing about almost 70%, nearly three-quarters of the spore mold sampling that was done on the indoors. All right, so that's sampling there. For patients, you want to use it judiciously. You don't want to sort of scatter shot particularly IgE testing there, or you can do skin prick testing for them there. Many people will prove to be allergic to molds and fungi outside of the occupational setting there from sensitization earlier in life or sensitization around the home. So those are false positives. And there could be false negatives. Not all tests are available for all types of molds or fungi that you might see in the workplace. For HP, the IgG or serum tests are small in number. The commercial panels, as I mentioned, pick out about 6 or 8 of the most common antibodies, but don't necessarily sort of cover all of them there. And oftentimes, particularly in farmers, many will exhibit sensitization in the sense that they have a positive IgG or precipitin test to actinomyces, but many of them aren't ill. So you want to use those in combination with demonstrable illness and the CT and the pulmonary function tests. So see, we're getting low on time. I'm going to sort of talk very briefly about the solutions, and we'll talk about treating patients in a minute, but you want to try to advocate and fix and remediate the underlying causes. So you can scrape off the mold, you can cover it with bleach, but if you haven't fixed the leaks and the condensation sources and the damaged building materials, those fungi are going to kind of keep growing within that area. You want to clean out the HVAC system. You want to ensure that it's working well. All of these things, again, sort of sound like no brainers, but there's oftentimes not the financial or the political will within that to provide the solutions to remediate. So, but you can't just scrub off the mold and expect everything, particularly patient or worker complaints or their illnesses, to go away if you don't address the under, and I mean by you meaning the company or the municipality or the school, to remediate that. Um, Workers should be removed if the condition is severe and progressive, and asthma and HP are sort of the two big ones there. The prognosis for occupational asthma is going to be related to duration of exposure to the instigating agent. And remember that those agents are also going to be oftentimes encountered in various places outside of work, fungi and molds being ubiquitous as well. Standard therapy, so combination inhalers, inhaled corticosteroids, and long acting bronchodilators, useful steroids for hypersensitivity pneumonitis. But again, your patients and workers aren't going to get any better if the exposure continues on there. So either the workplace needs to be remediated or the worker needs to be removed from that environment. Problems are, of course, evident there. Workers' compensation and other legal venues and remedies may want a high standard that we oftentimes can't meet necessarily by causation. And that's why sort of talk about air sampling is oftentimes that they'll want demonstrable air sampling and link molds to allergy testings. And many times and cases you're not able to do that there, yet you may be able to still make a case that your patient is exposed, to use all the occupational medicine weapons in your arsenal, that people are exposed and they're ill when they're at work and exposed, and they get better when you're not exposed, perhaps exclusive of even some kind of treatment there. So you want to try to meet the standard, but you also want to advocate for the patients and whom you know about that it may be that just sort of mindlessly testing things doesn't necessarily give you the whole story there. The problems with building ownership and responsibility are considerable. You don't want to necessarily sort of think this, but you'd want to think that perhaps building ownership uh, considers the workers' comp case, or the losing the worker is small enough financially compared to what they consider remediating the building for. So I'm going to sort of stop right here there. I think this is being recorded, but there's sort of been a number of good guidance, some of these getting a little bit old, but I think they still continue to be adequate and appropriate, and really quite useful for clinicians in dealing with mold. This is a group at UConn, including the late Dr. Eileen Story, who was really the motivating factor behind many of these clinicians' approaches to diagnosis and treatment for mold exposure. And with that, I'm going to this is a lot to take in, and I see the clock hitting 1 o'clock, and this is exactly like drinking like from a fire hose. I'm going to turn it back to Daniel Tarkington and see if there's any questions we may be able to, with those of you who want to spare a few minutes to, excuse me, ask questions, happy to answer them.
Yeah, so please submit your questions in the Q&A. We only have a couple minutes here. I don't see any questions now except for if we're going to be sharing the slides or anything. We will be uploading this course to our YouTube channel, so keep an eye there. We also will send a link of that around to all the participants. I also just want to take note, if you could, please complete the evaluation form that's in the chat. That helps us tremendously. Can I go ahead and share my screen really fast just so I can share the QR code?
Go for it.
All right. So if you want to scan this QR code, if you don't see the link in the chat, please just make sure to complete the evaluation form. Again, it really helps us. I also will be sending certificates to everyone who attended the course within the next week or so. So you should see an email from me with that certificate. If you have any questions that come up later on, feel free to respond to me. I can get those questions to Dr. Meyer and we can make sure that we address them. I do see a couple questions here in the chat. Dr. Meyer, if you have a couple minutes. Dr. Serbu said, "Hi, Dr. Meyer, thank you for your presentation. If we have a patient who are concerned for mold-related symptoms, can we send to a Selikoff for evaluation, even if the threshold for workers' compensation is very high?"
Yeah, sorry, Daniel, can you hear me?
I can.
Still, yeah, okay. I had one of these pop out here. Yeah, absolutely. If we're concerned for that, there. I mean, I think we just begin with a good history, and then we can also the other point I'll take, Dr. Serbo, is that if you're concerned with pulmonary disease or respiratory airways disease, they should be evaluated there, and we can look at the potential causes. We can see what they can be ascribed to, and we can see whether or not remediation, job reassignment, any of those things. If there is a good question for mold, sometimes we can work within other forms, such if we're able to demonstrate illness, but we don't hit the sort of workers' compensation uh, sort of thresholds, or if they put up high hurdles, we can oftentimes work on other mechanisms, such as the Americans with Disabilities Act, to try to get them job reassigned and still working. So, absolutely, yes. Looks like a second question. Dr. Seegers anecdotally shared with archivists who are exposed to mold. It does sound familiar. I'm trying to think of a case where I've had it there, but just, yeah, dust and spores and archivists. And again, most of those places are very poorly ventilated. So you get kind of the combination of one thing on top of each other there. So we have seen, and I think one of our patients that I mentioned with HP was in a library, but that was mainly related to water incursion. But remember that water is not only going to stay on the ceiling tiles and around the windowsill areas, but maybe also getting into the books and archives that are there. So those are, potentially considerable sources, and it sounds familiar. I can't necessarily quote you specifics of a case that's coming to mind right now, but you'd be absolutely on target with that.
And I think with that, that's the last question in the Q&A. Is there anything else you wanted to address, Dr. Meyer?
No, I'm good. Thank you for the opportunity. As you saw from my last slide there, this is drinking from a fire hose, and we tried to condense in an hour what's the subject of a couple of really sort of book length guides to assessment of indoor air quality and exposure. So much more to be learned, much more to look for, and the only other point I would say would be to have a high index of suspicion for those things there, particularly for hypersensitivity pneumonitis, which I think, again, I would say is probably underdiagnosed and either gets pigeonholed into pneumonia acutely or asthma more chronically. But to sort of think about that disorder as being much more common in exposed workers.
Great. Yeah. Thank you so much, Dr. Meyer. Again, just a reminder, please do the evaluation form. If you have any questions about anything, feel free to shoot me an email following the course, or respond to the certificate that I will send in about a week. So I appreciate you all for joining. Thank you so much, and we'll see you at our next CME course. Thank you, Dr. Meyer.